Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. If you work in mental health long enough, you will eventually face this moment. A patient sits across from you and says, "I've been on this medication for years," or "I'm terrified to stop," or "Every time I try to taper, everything falls apart." Benzodiazepine tapering is one of the most anxiety-provoking tasks in clinical practice for patients and clinicians alike. Not because it's impossible, but because it has been mishandled so often. So today, we're going to talk about how to taper benzodiazepines safely, humanely, and without damaging the therapeutic relationship. This is not about punishment. It is not about moral judgment. And it is not about abrupt discontinuation in the name of policy. It is about physiology, trust, and clinical discipline. Let us start with the most important principle. Benzodiazepine dependence is a biologic adaptation, not a character flaw. When someone takes a benzodiazepine regularly, especially over months or years, the brain adjusts. GABA receptors downregulate. Excitatory systems upregulate. The nervous system recalibrates around the presence of the drug. So when the medication is reduced too quickly, the brain doesn't interpret that as treatment optimization. It interprets it as a threat. That's why withdrawal symptoms occur. Anxiety, insomnia, tremor, sensory hypersensitivity, panic, depersonalization, even seizures in severe cases. These are not psychological weakness. They are predictable neurophysiology. And this is where many tapers fail. They fail because they are rushed. They fail because they are forced. They fail because the patient does not trust the plan or the clinician. So let us reset the frame. A successful benzodiazepine taper is not about speed. It is about stability. The first step is deciding whether tapering is appropriate now. Not every patient on benzodiazepines needs to taper immediately. If someone is medically unstable, actively suicidal, in uncontrolled withdrawal from another substance, or facing acute trauma, that may not be the moment to initiate a taper. Tapering should begin when there is enough stability to tolerate discomfort without destabilization. Next comes the most underestimated step, collaboration. If the patient feels coerced, the taper will fail. If they feel blamed, it will fail. If they don't understand why tapering matters or how it will be done, it will fail. The conversation matters as much as the schedule. Patients need to hear three things clearly. First, "I believe you when you say this medication helps." Second, "I'm concerned about the long-term risks, not judging past decisions." Third, "We will go at your pace your nervous system can tolerate." Without these assurances, you are fighting biology and psychology at the same time. Now let's talk mechanics. In general, slower is safer. For long-term benzodiazepine users, especially those on daily dosing, abrupt discontinuation is dangerous and unethical. Rapid tapers increase the risk of severe withdrawal, rebound anxiety, seizures, and long-term sensitization of the nervous system. A common mistake is reducing doses by arbitrary amounts or fixed time frames without regard to symptom response. Instead, tapering should be symptom-guided. A typical starting point is a reduction of about 5 to 10% of the total daily dose every 2 to 4 weeks. Some patients tolerate faster. Many require slower. There is no universal schedule. As doses get lower, reductions often need to become smaller and slower. This is where clinicians sometimes misinterpret resistance as noncompliance. In reality, the nervous system is simply less forgiving at lower doses. Another key decision is whether to switch agents. Short-acting benzodiazepines tend to produce more interdose withdrawal and rebound anxiety. In some cases, transitioning to a longer-acting agent can smooth the taper by providing more stable blood levels. That decision must be individualized. Switching medications can help some patients and destabilize others. There is no one-size-fits-all approach. What matters most is consistency and predictability. Once a taper step is made, hold the dose long enough for the nervous system to settle before making the next change. If symptoms flare, that does not mean the taper has failed. It means the pace may need adjustment. Now let's talk about adjunctive supports, because tapering should never be done in isolation. Non-benzodiazepine anxiolytics can play a critical role here. Agents that stabilize baseline anxiety without causing dependence, such as buspirone, certain SSRIs or SNRIs, or carefully selected off-label options, can reduce the overall anxiety load while tapering progresses. Sleep deserves special attention. Rebound insomnia is one of the most common and distressing withdrawal symptoms. Addressing sleep with non-benzodiazepine strategies, be it behavioral, circadian, or pharmacologic, can make or break a taper. Psychotherapy is not optional in long-term cases. Not because withdrawal is all in the head, but because patients need tools to interpret bodily sensations without catastrophic meaning. Anxiety during tapering is often amplified by fear of the symptoms themselves. Education reduces fear. Predictability reduces panic. Support reduces dropout. Now, let's address a critical point clinicians sometimes miss. Withdrawal symptoms do not mean the underlying anxiety disorder is coming back. This is one of the most damaging misinterpretations in benzo tapering. Withdrawal anxiety feels intense, unfamiliar, and often worse than the original symptoms. That does not mean the patient needs the benzo forever. It means the nervous system is recalibrating. Differentiating withdrawal symptoms from relapse requires patience, longitudinal observation, and clinical judgment, not reflexive dose reinstatement. That said, flexibility is part of good care. If a patient becomes significantly destabilized, like if they're unable to function, sleep, or maintain safety, it is appropriate to pause the taper or make a small upward adjustment before proceeding more slowly. This is not failure. It is harm reduction. So let's talk about the endpoint, because tapering without a destination creates anxiety. Patients need to know whether the goal is full discontinuation or dose reduction. For some patients, especially older adults or those with long-standing use, the goal may be a lower, safer dose rather than complete cessation. That decision should be individualized, revisited, and documented. The worst outcome is not a slow taper. The worst outcome is a rush taper that leads to patient disengagement, emergency care, or loss of trust. So let's bring this home. Benzodiazepine tapering is not about enforcing rules. It is about restoring nervous system resilience while preserving dignity. It requires patience, flexibility, education, and collaboration. It requires resisting pressure to move faster than physiology allows. And it requires remembering that trust is a clinical tool, not a soft skill. When done well, tapering can be empowering. Patients often discover that their anxiety is more manageable than they feared, that their cognition improves, that their sleep stabilizes, that they feel clearer, steadier, and more in control. When done poorly, it can re-traumatize and destabilize. The difference is not the medication. It's the method. And when clinicians lead benzo tapering with humility, structure, and respect, outcomes improve for everyone involved. Thanks for listening. If you found this episode useful, please share it with colleagues across disciplines. And watch out for the next episode where we give examples on how to taper specific benzodiazepines.